Yeah. Uh, Hello again, my colleagues, in our third Mixed Viva case session. Before we start, I wanted to give you some pieces of advices. Uh, as the exam is about just 20 days, so from today, try to be concise and try to be connected and very near from the exam style. First, you should talk about the technique that you are presented with. While you are talking about the technique, try to screen the exam at maximum at 10 seconds, and then stop at the point of interest, the point of pathology, keeping in mind the history that the examiner just informed. Third, try to describe in short, concise bullets. Too much verbosity annoying the examiners. Okay? And they try to describe first the related pathology and exclude the related negatives. This is the most important. And then give differential diagnosis, and it must, not should, it must be related to the pathology. And then your next step, either radiological, non-neurological, and you describe the management, including interventional radiology, transfer to another specialty, uh, upon coma center. Anyway, like this. My advice to all of you, don't wait until the examiner asks you in any of these four stations. Okay? If he asks you, this is means you are losing marks because this is your role to describe step by step, like in the practical life. Okay, my colleagues, four stations, four steps you must fulfill before the examiner asks you. Let's start with our first candidate.
Yes, sir. Can I start or?
Yes, uh, my screen now is, you see my screen visible?
Yes, sir. Yes, sir. I can see your screen.
Yeah. Okay, you can request the control.
Yes, sir. I have requested.
Okay. 35-year-old male patient complaining of abdominal pain and distension.
I have been provided with a frontal radiograph of an abdomen, including the lower chest and the upper pelvis, of a patient who is presented with a complaint of abdominal pain and distension. Looking at the radiograph, I have first noticed that there is evidence of distension of the abdominal cavity. There is a paucity of the gas noted within the abdomen. Um, the bowel loops appeared slightly collapsed. There is no any evidence of portal venous gas or any evidence of nematosis intestinalis. There is soft tissue density noted in the left side of the abdomen in the lower abdomen.
Yes.
Oh, this is concerning for some mass lesion within abdomen. So I will proceed with further cross-sectional imaging, including the contrast and CT scan of the abdomen for further evaluation.
One, you can store.
Okay. I have been provided with axial CT images of an abdomen of a patient. So I will going to the top and so I'm scrolling from top to bottom. Um,
Yes.
I can see there is evidence of large
Yes.
fat containing lesion with internal vascularity
Yes.
seen involving the both kidney.
Excellent.
Um, they are quite large, occupying whole of the abdomen. extending down to the pelvis. The bowel loops appears collapsed and within the lower pelvis.
Yes.
There is no any evidence of hemoperitoneum. Um, so these are large fat containing lesion. I'm thinking of bilateral renal angiomyolipoma.
And
The pelvic cholesterol system appears to be stretched, but there is no any hydronephrosis in the given images. There is no any evidence
yes,
of rupture of any lesion. So in this patient, I am thinking bilateral angiomyolipoma. I'm thinking of tuberous sclerosis in this patient. So I will inquire about the patient previous history and look at on the previous imaging, and also inquire about the patient history if patient is a known case of tuberous sclerosis. If not, then MRI whole neural axis can be done to see further lesion. Uh, can I see the bone window and the lung window to see if there is any involvement of the lung and bones?
these are
Okay.
other than this abdominal CT. What do you want to do for this patient?
Yes, MRI whole spine, MRI whole neural axis, plus I will see the chest to see if there is any involvement of the chest to rule out any lymphangiomyomatosis. And
Yes. This is a
yeah,
CT brain.
yes, I have been provided with the axial CT scan of the brain of a patient. Here I can see there are multiple calcified subependymal nodules are seen. I want to see the at a level of a foramen of Monro. There is some mass lesion with solid component noted at the region of foramen of Monro. I am suspicious about this. This can be a subependymal giant cell astrocytoma. So I will go with the post contrast images of this patient if available. And I'm looking if there is any cortical tubers. I'm looking at the cortical tubers like a hypodense area at the region of the frontal cortex. Um,
What is the complication caused by this foramen of
yes,
Montgomery?
there is a hydrocephalus.
So
Ventricles are
what will you
dilated.
do?
Yes, I
What
will
will you
urgently
do?
inform finding to the neurosurgeon as there is a hydrocephalus, so it is an emergency condition, so required a VP shunt placement, um, and also neurological MDT referral for further management.
Thank you, Dr. Aroshni, so much. Dr. Aroshni, one of the excellent style RCR Viva hot seat. Really, I appreciate her style too much. See here, you did very well
Thank you, sir.
when you didn't satisfy of search. This is very clear case. As before, I told you, my colleagues, many times when the examiner give you something very obvious, يعني, keep in mind there are something other he want from you. In this case, hello, am I audible?
Yes, sir. Yes, sir. You are audible.
Okay. In this case, this is the first point. See, mass. This is SIGA, subependymal giant cell astrocytoma. Okay, and at least mild hydrocephalic changes. At least this is the most important issue. This is the most important finding in this exam. See, from the beginning, it is an easy case. Very clear. This is angio bilateral extensive, large exophating multiple angiomyolipomas. Okay, this is very easy. Okay, the point is not here. The point number one is there are hemorrhage or not. I don't know, Dr. Aroshni, this is soft tissue or hemorrhage. We don't know exactly, but almost it may be soft tissue. However, however, if we examine here, this is also delayed or non-contrast. This is non-contrast. Okay, and here also all the CT is non-contrast. Anyway, the most important point in the abdomen to rule out any hemorrhage. As long as the patient is hemodynamically stable, I think this is all the left side is this is a renal tissue. The point is here. The trick is here, my colleagues, in the CT break. So take care of satisfaction of search. Okay, my colleagues, thank you so much, Dr. Roshni. Second candidate.
Thank you, sir.
Second candidate.
Yes, doctor.
Welcome. Could you request control, please?
Okay.
50-year-old male patient complaining of intermittent bilateral anterior knee pain, and he has a history of surgery.
Yeah,
Go
I'm
on.
trying to scroll. I will go till the last cut and then give my comment.
Yes, tell me what is the technique? I told
Okay,
you.
I'm presented with MRI knee axial cuts,
Yes.
proton stair.
Okay. Fat set. At least you can tell the examiner this is fat set.
Okay.
Okay.
He has anterior knee pain, right?
Yeah, he has a, yeah, okay. He has a pain and he has underwent a surgery. You can also see this is the sagittal if you want.
Yes, please.
This is the corona. This is the sagittal. This is sagittal. Go on.
Sorry, I can't. I'm trying to scroll.
Yeah.
There is the striking abnormality. There is joint effusion and much edematous changes. I'm looking now at the menisci.
Yes.
The medial meniscus is okay, unremarkable. The PCL,
Mhm.
the PCL show hyper intense signal, partially hyper
No,
intense signal. Maybe
don't worry. No, no, no,
okay,
no, don't worry. This is a normal appearance of the ACL.
okay. PCL, PCL,
Also
PCL is
BCL
good.
normal.
Okay,
Normal. BCL is one of the rare ligament to be injured. It
yes,
need a major extensive trauma.
okay.
Doctor, you have an echo from your side.
Can you hear me well
Yeah,
right
yeah.
now?
Go on.
Okay.
Go on. Go on.
I'm looking now at the lateral meniscus. It's also likely unremarkable.
Yes. Mm. The medial meniscus also. For time being, look at the
Okay.
axial. Look at the axial. The clue is here. Yeah, go on. Yeah, scroll. You can scroll.
Install. Okay. The abnormality is in the last cut here, or I can't catch
No, in the
abnormality.
axial. In the
Okay.
axial. In the axial. Here. Stop. Here, the abnormality is here. What happened here?
No signal void.
Maybe there is the lateral patellar slide dislocation, or no?
No. No.
No, I don't know.
Let's see. See,
No
we
signals,
are,
no?
see, we are, no, there are signal void here and almost here. Okay.
Yes.
See, we are scrolling from up down. Look here, and tell me what happened. What happened here? What happened here? Here, what happened? And then see, they come again to each other. So
The
there are
artery
some,
and the vein,
yeah, there are,
there's
the
muscle
abnormality is here. Yeah, correct. What happened? Tell me.
entrapment syndrome,
Okay, yeah, describe what happened.
medial head gastrocnemius
Okay,
is between the artery and the vein, compressing
excellent,
the popliteal artery.
excellent. Again, is stop. No,
Okay.
go back. Against what is this structure?
Femoral distal femoral condyle,
Excellent. So what's your diagnosis?
popliteal entrapment syndrome,
Excellent. The cause is this medial head of
gastrocnemius.
what's your next step?
I will convey my findings to the referring physician and vascular surgery for release of
Yes.
this compression.
Okay. Could you confirm this diagnosed by ultrasound?
Maybe in Doppler basis.
Yes. How? Tell me the technique. What will you ask the patient to do?
No, I don't know.
You will do a Doppler and you will ask the patient to do something at his ankle. When he do something, some action, the muscle will contract, and
Maybe flexion
so
extension. Yes.
okay, which type? Plantar flexion
Okay.
or extension? Plantar flexion.
Plantar flexion.
Yeah, when you ask the patient, you will put the probe here. Okay, in
Okay.
neutral position, the flow will be a normal flow. Then ask the patient to do a plantar flexion. So
Yes.
the muscle will contract and compressing and medially displacing the popliteal artery. So
Yes.
the resistance will increase here.
Okay.
Okay. There are must some changes in the flow and resistance at big systolic velocity in the popliteal. Thank you, doctor, so much. This
Thank
is
you, doctor.
one of very snacky cases. So
Yes.
my colleagues, thank you, leave the mouse. So my colleagues, take care, don't satisfy of search. The patient has here some edema, okay? The BCL and ECL is normal, both of them. Lateral meniscus is normal, okay? Medial meniscus have something here, also minimal finding. So you must search others, like coronal. Search for medial collateral ligament injury and lateral collateral ligaments. Okay, even any edema, any OCD, osteochondral defect, and don't forget axial. Why this case is very difficult? Because most of us neglect the axial in knee. When see here, this is from top down, down, down. You must see this is the artery, this is the vein. You must see them adherent to each other. Then there are a separation. Why? This is a slip of the medial gastrocnemius head, displacing and compressing the popliteal artery against the medial femoral. So this is a case of popliteal artery entrapment syndrome. Thank you, doctor, so much. Candidate?
Hello.
Hello, doctor.
Hello. Good afternoon, sir. Candidate 3 here.
Yeah, 12-year-old
Yeah,
patient presented with dyspnea
okay.
and tachypnea. Go on.
Okay. 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 So this is frontal chest radiograph of a skeletally immature patient, where I can see there is large homogeneous opacification in the right hemithorax.
Yes.
Also, I can see that the heart outline is not seen, so it appears to be deviated to the same side, and also there is herniation of the contralateral lung across the midline. So I am thinking of some pathology which has some element of collapse in it. Sir, age was 1 year,
12 years old.
5 years old. So with this ipsilateral displacement of mediastinum, I am thinking of this could be due to pulmonary hypoplasia or agenesis as my first differential.
What will you
And also
indicate?
I can, because yeah, others is the ribs also are crowded. So I will for confirmation I will suggest for CT scan to CT scan chest.
No, other than CT scan,
Uh, uh,
you can
oh,
do
okay,
something very simple. Very simple.
okay.
Mhm.
E ultrasound.
Before ultrasound.
Ultrasound. Okay.
Mm.
Expirate, but expiratory won't help here.
No, no, no. Should you ask
Uh,
about something?
uh,
Should you ask about something?
uh,
Should you revise
uh,
something old?
other possible differentials are there like CPAM and all, but they will cause will cause the mediastinal shift to other side. So with ipsilateral mediastinal shift, either one is collapse of the lung, other is pulmonary agenesis. I will ask for also the concern for any foreign body ingestion is the second concern. So I will ask for history of any foreign body aspiration.
Doctor, before asking
Hmm.
for input, why
Hmm.
didn't you ask for all the images? Why didn't
Yes,
you
sir.
ask if
Sorry,
the patient, if
sorry, sir. Yeah,
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 yeah.
if this
Hmm.
is a chronic case, chronic disease,
Hmm.
if this is since a childhood, this
Hmm.
is very simple, and it will not
Yes.
cost you or the patient or
Yeah,
the
yeah,
NHS.
yes, sir. Yeah,
So,
yeah, very
so
sad.
what is your first action? Tell me,
Yeah, correlate with the previous imaging. Yes.
and the previous history, and then if there are no any previous, see, you can do
Hmm.
CT.
Hmm.
This is the CT.
Okay. Okay.
Go on.
So
Mm.
I can I think I can control every question again. Okay, I'm using the arrows.
No.
Oh, sorry, sir. Something else came. Hmm.
Okay, leave
Hmm.
the mouse.
Okay, yeah, I left this.
On.
Yeah, yes, sir. So I've been provided a CT scan chest, axial sections of the I'm scrolling, and this is contrast study. Okay.
Yes.
In this, I could see that there is a this confirm my finding of the mediastinal shift and collapse. So can I go above?
Yes.
Yeah. This confirm my finding of almost rudiment. The heart is shifted to contralaterally to the right along the right chest wall, and rudimentary lung. Sir, can it go above little more? It's not taking from arrow. And the left lung, I'm tracing the bronchus. I could not see any bronchus also within the bronchial branching on the right side. So this appears
Excellent.
to be complete pulmonary agenesis
Thank you,
rather than
doctor, so
because I could
much.
not see any bronchial. Yeah. Yes.
Thank you, doctor, so much. You did very well.
Okay.
Uh,
Yeah.
the
Thank you,
moral
sir.
from the moral from
Hmm.
this case to ask first for any history since
Yes.
childhood, any old examination. This is very important. Okay, thank you, doctor, so much.
Hmm.
Next candidate.
Yeah. Thank you, sir.
Welcome.
Good afternoon, sir.
Candidate. Good
Yes, sir. Good
afternoon.
afternoon, sir.
Good afternoon.
I've been.
Uh,
Good afternoon, sir. Yes, sir.
ask for control,
I've been.
please.
Yes, sir. So requested.
This patient has chronic back pain. Go on.
Sir, is it the same patient?
No, another patient.
Okay. I've been provided with MRI images of a patient who's complaining of chronic back pain. I'm just taking, I'll take a moment to scroll through the images. Sir, I'm not able to scroll.
Please do not.
Yeah. I've been provided with, so can I scroll now? Or is it a single image, sir?
No, I think this is no single image. Okay, go on.
No, sir. I've been provided with MRI sagittal T2-weighted images of a patient who's complaining of backache. I can see that the vertebral body is appear reduced in height. That is seen throughout the lower thoracic as throughout the vertebral spine. That is the thoracic as well as the lumbar spine. Uh, uh, Likely giving a bullet-shaped configuration.
Mhm.
There is also posterior scalloping of the vertebral body seen involving the lower thoracic vertebra out here, sir. I would like to look at the axials further to.
No posterior scallop. See like that. Normal.
Sir.
No posterior scallop. What's your differential diagnosis? Look again here. What's your differential diagnosis?
Uh, so I can't,
What happened? What happened here?
yes, sir.
Here.
Actually, there is there is biconcave appearance of the end plates noted involving all the vertebral bodies.
Okay, this is not biconcave. This is looks like depressions.
Yes, sir.
So what's your differential?
Sir, it could be hemoglobinopathies like sickle cell anemia or
Okay, what will you make
Gaucher's
it?
disease. I would like
Okay, what else?
to do further imaging of the patient with a USG to look for spleen. Or,
This
okay,
is a skeletal survey.
okay,
Okay.
sir. Okay. Okay. I've been provided with frontal images of the hand of the same patient.
Yes.
I'm just taking a moment to look at the images. I'm tracing the cortices all the bones. There appears to be diffused uh, there is appears to be increased bone density seen involving the uh,
What else?
bilateral.
What else? What happened in the wrist bilaterally? The claw is in the wrist. And see,
There appears to be arthritic changes seen involving the radiocarpal joint.
are
There is
you
reduced
sure? See, are you sure this is arthritic changes? Look here
reduced
at the
reduced
wrist.
joint space involved.
Okay, and here. What happened? What happened
Uh,
in a specific anatomical location? Here, 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 and in the spine, the vertebra. What happened?
so there is changes of bone infarction, like avian and bilateral femoral head. Then
Yes.
there is
Okay. Yes. There are something in the head here, and
yes,
where
yes,
here?
sir.
In the head
So there
itself,
is
or a specific part of the head?
Uh,
What is the name of this part?
sir,
This part.
epiphysis, sir.
Okay, what happens for the epiphysis here, here, and here? What
So there
happens?
is epiphyseal dysplasia.
Okay, excellent. What happened here? The spine, to the spine.
So there is
Mm.
sclerosis
Yes.
involving the upper as well as the lower end plates of all the vertebral bodies.
Yes, so give me a differential diagnosis for all this finding.
Uh,
Normality in the vertebrae and in the in the vertebrae and
yes,
in
sir.
the epiphysis. Hmm. What do you think?
Sir, he uh, blood pathology like
Okay,
sickle cell anemia or Gaucher's
okay.
disease,
What else? Gaucher disease is correct. Yeah, would we include? What else?
or thalassemia.
No. What else? What is the syndrome that may include the spine and the epiphysis? It has a specific name.
Multiple epiphyseal dysplasias.
Okay, epiphysis only or epiphysis and the spine?
Sir, I can't think of.
Yeah, so this is spondylophysial dysplasia.
Spondyle
Okay. And this is
epiphyseal
one of
dysplasia.
the, okay. This is one of the very important differential diagnosis of mucopolysaccharidosis. And if you told me here, doctor, it may be mucopolysaccharidosis, this is acceptable. But plus
Yes, sir.
spondyloepiphyseal
Dysplasia.
dysplasia. Why? The spine here is not normal. All
Yes, sir.
the spine. But there are no
Yes, sir.
anterior peaking. Yani, frankly, there are no anterior peaking. And
Yes, sir.
when I show you the skeletal survey, see, all the epiphysis is dysplastic. So if you told
Yes,
the
sir.
examiner, oh, I could see the dysplasia of all the epiphysis in the wrist and in the pelvis, in the epiphysis of the femur. Okay, what is the definition of epiphysis dysplasia? This irregularity, this deformity. Okay,
Yes, sir.
so this is a case of spondyloepiphyseal dysplasia. Thank you,
Dysplasia.
doctor, so
Okay, sir.
much.
Yes.
Thank you.
Thank you, sir.
Next candidate.
Good afternoon, sir. Candidate 5.
Yeah, fully good post control.
Yes, sir.
70-year-old
West.
female patient complaining of chronic hypertension.
Okay. I'm provided with axial coronal images of a 70-year-old patient
This is
with
axial.
chronic hyper.
Doctor, this is axial.
Sorry, sir. Coronal. Sorry, sir.
Sure.
Coronal
Okay.
axial CT images of a 70-year-old patient who with complaints of chronic hypertension. I would like to scroll through the entire extent of the images before I start to comment. I could see that the right kidney is smaller in size and shows reduced enhancement compared to left kidney. I am trying to see for the renal artery. Since the patient had complaints of hypertension, I can see that the renal arteries, accessory right renal artery, both renal arteries show contrast opacification. However, it shows narrow caliber compared to left. Also, I could see a hyperdensity involving the upper pole of right kidney. I would like to see it with compare it with a non-contrast study to see if it is hyper-enhancing lesion or a calcification. Apart from that, I am looking for any obvious enhancing focal lesions which could cause hypertension.
Yes. What else? What else? Doctor, why you are consuming too much time in coronal without asking others,
Yes, sir. Okay,
other
sir. Can I?
sections?
Yeah.
Yeah.
Okay. So can I take the Excel section, sir?
Okay, take.
Thank you.
If you ask the examiner, he may give you, and he may not. Okay, but if he
Okay.
didn't give you, this is means the answer in the corona. Okay.
Okay.
Why this left kidney, right kidney is too much small? What happened?
Uh,
What's your differential diagnosis for small? This is not small, atrophic.
Atrophic right kidney.
Mhm.
This could be probably be secondary to right uh, renal artery stenosis. I can see there is some significant narrowing involving the proximal right renal artery just adjacent to
Excellent.
the ostia.
Excellent. See,
So
doctor.
this,
See. So my colleagues, the technique in the exam is very critical. When our great doctor change her technique from go up and down, go forward and back in the same coronal, immediately she pick up the diagnosis here. So your technique, your reviewing areas is very critical. Okay, my colleagues? Yes, you answer everything. Go on. Mm.
yes, so this could represent renal artery stenosis, which is a very common cause of hypertension, refractory hypertension. So
What will you do next?
so this patient needs to be evaluated with in a DSA. Patient needs to be referred to interventional radiology
Why?
to look for renal artery stenosis and to plan renal artery probably dilatation of this stenotic
Do you
area.
think, do you think this patient will get any benefit from renal artery dilatation or angioplasty? Look at the kidney.
Yeah, it seems to be infarcted, sir. Yeah, yes, sir.
Atrophic.
Atrophic.
So before sending the patient to the intervention radiology, there are very important steps. There are very critical investigation should be done. See, look at this kidney and this kidney. See, Mm. Do you think is this functionally properly the right
No,
one?
sir. No, sir.
So before taking a decision of angioplasty,
So,
what do you want to do?
renal artery Doppler.
Okay, خلاص, you diagnosed from the CT, there are stenosis.
Yes.
I'm talking about the management. What is the next investigation should be done before angioplasty or to help you to do angioplasty or not? Which investigation?
So probably a DTPA scan or a MAC
What DTB scan?
to look for the functioning of the
Excellent.
preserved function of the right
Excellent.
kidney.
So you will refer the patient for a split renal scan to determine and to uh, tell us about the function of this one. Sure, this one is functioning, but is this functioning or not? This is very critical. Why? If this right kidney is not functioning, I think it is better to do a nephrectomy. Better because the patient has a refractory hypertension and he will not gain any benefit from a renal artery angioplasty at all because this is
Okay.
very chronic. Okay, my colleague, see,
Yes, sir.
the renal artery is markedly narrowed. So we should tell the examiner, we should speak with the examiner like physicians also because FRCR 2B is a clinical examination, clinical radiology. So we should tell him first, we will request a splitted renal function isotopic scan. And after that, if this function, I may transfer to intervention radiology. If not function, I will transfer and to his urologist. And I think it is better to remove the skin. Like this, the examiner will be so happy. Why? Because you talking to him from a clinical radiology point of view. Thank you, doctor, so much.
Thank you so much.
Next candidate. Next candidate.
Yes, sir. Good afternoon.
Good afternoon. This patient, 40-year-old male patient, has vague right testicular pain about 1 week.
Okay.
This is only a static image.
Here I am presented with the high resolution sonography of the right testicle. Here I can see that there is a heterogeneous area is noted at the in the testicular parenchyma with heterogeneous hypoechoic areas within it with peritesticular vascularity. Minimal fluid is also present. So this can be because patient presented with the testicular pain. So this can be a area of the testicular infarction and testis maybe with the testicular torsion. So this is a urgent emergency. I will check the other set of the images for the swelling sign or the button.
But the patient has a central arterial vascularity. What's other differential diagnosis?
Other can be it can be testicular mass because there are few areas of internal vascularity are also there.
Okay,
I will
what's
check
your
the whole
next
set of.
step? What's your next step?
Yes, after checking the whole set of the images, this can be the seminoma. So I will check for the contrast enhanced CT scan, chest and abdomen for the staging CT to look for any retroperitoneal lymphadenopathy.
Before staging CT, what will you do first? Before staging, we don't know if this is infarction or seminoma. What is the next step?
I will compare with any previous imaging available.
No previous image. What is the next
I
step?
will check with the
testis?
clinical history. I will check with the clinical history of the patient if there are raised inflammatory markers are there.
Doctor, you have something in the testis, and the sonar is not conclusive. What is the next investigation? What is the next radiological examination should you do for the testis?
For the testes, MRI testes?
Yes, very easy. Very easy. Okay. Can you request control, please? Hello?
Hello?
Doctor,
yes, sir. Right
control?
now I am on phone. I am phone. I could
okay,
not
okay. I'm scrolling for you. Tell me. Tell me the technique and go on.
In the right testicle,
what is the name? What is the name of technique? What is the name of this technique?
Yeah, this is the MRI of the scrotum fat set sequence.
Yes. Fat set only. What is this? What is this? Is this contrast or non-contrast? Look.
This is post-contrast images because I can see the vessels.
Yeah. What happened?
Left testicle is properly enhancing and left testicle is enhancing properly. Right testicle is slightly small in size with heterogeneous signal intensity areas with no proper enhancement within the right testicle. So this can be testicular torsion. I am checking for torsion? The swirling.
Doctor,
yeah.
Doctor, again. Okay. See, this testis looks like enhancing like this. Okay. But there are some abnormality. Where is the abnormality in the right? Where?
There are few hypointense areas are there within it. The
hypointense,
right.
Doctor, hypointense or non-enhancing?
Yeah, these are non-enhancing areas. These are the post-contrast images. So they can be that areas of testicular infarction. Yes, there on the T1 bedded image, there is an area of hemorrhages also there.
Yes.
Yes. Yeah.
So give me differential diagnosis.
Yes. So this can be testicular infarction with intratesticular hematomas due to the testicular infarction, and
okay. Okay. What is your next step?
because this is a acute emergency, I will urgently pick up my phone and urgently inform the finding to the referring physician and urgent referral to the urologist for the
Proper
detorsion or
management.
the removal or the
No,
further management.
yeah, further management. Why? Because this is not torsion, doctor. This is just segmental infarction here. Here, one segment of the testis due to one segmental artery, but rest of the testis is normal. Okay, this is very important. Thank you, doctor, so much. This is one example of an easy case, but a little bit snacky. See, this is the left testis. This is the right one. At least there are a wedge shape, hyper signal T2 fat set abnormality surrounded by this dark signal. Looks like a little bit serpentinous double rim, but this is not acceptable in tests, but this is just to facilitate. Okay, and we are suspecting from ultrasound it may be an infarction. See, this is peripherally based at the capsule area of avascularity here. So this is testicular infarction. Thank you, doctor, so much. Next candidate.
Candidate 7 here. Hi, sir.
Please come. What do you request?
Yes, I've requested control.
45-year-old male patient complaining
45-year-old male patient with, sorry? Headache. Okay. I'm just taking a moment to scroll through these MRI sequences of a 45-year-old man with headaches. Okay. I'm starting from the top. So I'm looking through the sequences of the MRI head. This is a flare sequence. I can see that there is pachymeningeo enhancement peripherally, suggesting
sure?
possible. Sorry?
Are you sure this is enhancement in flare? You said this is. So this is enhancement?
No, not enhanced because it's not post-contrast. So there is a high signal in the periphery. I would like to look on post-contrast images.
Is the mouth?
There is thickening. Yep.
Okay. Go on.
So I'm looking at the T1 post-contrast images.
Yes.
Okay, so there is no, sorry, I'd like to retract my previous statement. There is no pachymeningeo enhancement that I can see on the post-contrast images. I would like to look at the T2 axials, if that's possible.
Doctor, the last sequence for you of this one. The examiner will not give you more than two, by the way. Two sequence is more than enough. Three, if the case is very difficult. Tell me your differential diagnosis, please.
So I'm just looking at the sagittal views of the brain in T1. I'm just no, this is sagittal T2. I'm just looking.
This is not T2, doctor. Sagittal.
No,
okay.
This is just a sagittal flare.
Okay.
On sagittal flare, I can see that there is. Okay, I'm just looking at the rest of the film. Okay.
Doctor, the answer is here in these slides. Don't move. The answer is
Okay.
what happened here.
I mean, the only significant abnormality that I can see is that there is low signal seen within the ponds.
The ponds is okay. What
Okay.
else?
Just looking at the rest of the film, there is. I'm not sure if there is a tonsil descent. So there is tonsillar descent.
Where is the tonsil? 1 second.
Sorry.
My colleague, mute yourself, please. Okay.
Nothing strikingly obvious on this. I'm sorry.
So what happened here? See, what happened here? What
Okay,
happened here?
Fine. Okay, so there is a posterior focal cystic, low signal region seen posterior to the cerebellum.
What is
which
the name? What is the name of this structure? See. What is the name?
Oh, is it just the transverse sinus? Or,
okay, what happened for the sinuses? And what happened here for the basal cisterns?
Okay, is this? I understand. I think there is low attenuation change in the pons, and there is possible sinus signal flow void. I did actually see hyperdensity to the basilar artery. I'm not sure if this is keeping with basilar artery stroke.
Doctor,
on the axial.
The signal void is preserved. Look here. Look here. Do you think this is the normal size of the ventricles? Do you think this is the normal size of the sinuses? See. This sinus is expanded or effaced?
Expanded.
Okay, excellent. This ventricles is expanded or reduced size?
Oh, okay. It's a reduced size. So is this in keeping with intracranial hypotension?
Yeah.
With the patient.
Yeah.
Oh, okay, fine.
Yeah.
And was it actually pachymeningeal thickening on the, or was that? So I know the signs are your empty cellar. You have your intracranial hypotension.
No, not empty cell. Empty cell is in intracranial hypertension. This is another end. Okay.
Oh, sorry.
Thank you.
Yeah.
Thank you, doctor, so much. My colleagues, from the beginning of your examination, every science must go must receive you to another step. What happened here? This is a flare, and what happens there are at least dural, epidural, subdural, anyway, abnormality, at least subdural. Okay, but actually this is a meningeal thickening. And when we go to this slide, post contrast, doctor, you must answer from this one. Why? Because there are diffuse, homogeneous, uniform meningeal enhancement, diffuse, homogeneous. So both your differential, doctor, it may be metastasis, it may be meningitis, it may be hypotension, nothing else. 3 possibilities. But doctor, I will exclude metastasis because it is uniform. So I will ask, doctor, is the patient has fever? No. So doctor, the most possible diagnosis is intracranial hypertension. Doctor, please, I want sagittal to confirm my diagnosis. If you look here at the sagittal, see, even the prepontine cistern is completely effaced. The sinus is dilated. Okay? There are no tonsillar herniation. The case will not come typical with false signs. Okay, my colleague? So from the beginning, put a map of differential diagnosis and then ask for other sequences to exclude one by one. Thank you, doctor, so much.
Thank you.
Next candidate.
Hello.
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 Ask control.
Okay,
What you-
I have requested.
Okay. 45-year-old male patient complaining of paraplegia.
Okay, are you scrolling, sir?
Yeah, go on. Okay, I will go on.
Okay, these are axial CT sections of the pelvis bone window.
Yeah.
I can appreciate that there are hyperdense focal areas involving the intramuscular
Doctor,
planes and subcutaneous
doctor, one
tissues.
second.
Sorry,
1 second.
sorry.
Are you scrolling, doctor? Scroll.
No, I'm not scrolling.
Yeah,
Sir,
okay,
you
scroll.
were
Yeah.
scrolling. I think you were scrolling.
You want me to scroll? Okay.
Okay, sir, you can.
Yeah. Mm.
So, these
Scroll.
are
First, doctor. First, take a
okay,
5,
I'm
10
scrolling.
second.
Yeah.
Yeah. First, take 10 second to see all the city first, and then try to describe according to the idea that you formed about this examination.
Okay, I'm scrolling above from bottom to top. I can appreciate that there are regions of calcification ring enhancing with ring like calcifications involving the bilateral psoas muscles. Also, I can
Excellent.
appreciate that there are calcified regions involving the vertebral body in the lower. I
Excellent.
will count this on the sagittal or the coronal views. Also, these calcifications are extending and involving the prevertebral and epidural spaces and also exiting foramina. Um, there are multi-level. There is involvement of multi-level disease process. Also, I can appreciate that there are multiple calcified mediastinal lymph nodes and multiple calcified granulomas in the visualized lung fields.
Yes.
In my routine practice, I would like to see the previous imaging for comparison. Also, like to take the history. However, in summary, in this case, the significant findings of bilateral calcification in the bilateral psoas muscles and multiple calcified regions involving the vertebral bodies with extension into the prevertebral space, paravertebral and epidural components, and multiple calcified lymph nodes, abdominal and mediastinal, and calcified granulomas. Likely, this is a case of previous hold multi-system involvement of the heel tuberculosis.
Excellent.
In my routine practice, I will like to see the lung windows and also abdominal window to see its activity. In this CT sagittal section bone window, I can redemonstrate that there is involvement of multi-level lower thoracic and lumbar and first sacral vertebra and also the gibbous somewhat gibbous deformity, and these are
Excellent.
involving the intraspinal components. Further supporting the diagnosis of previous tuberculosis. So. So that's why I will inform the finding to the referring physician. Also will suggest a referral to the neurosurgical. If there is any history of weakness of the lower limbs, I would suggest MRI of the lumbosacral spine.
Doctor, what happened here?
Sir, I think
Why?
this right psoas muscle bilateral. Also in the
No, no,
I
no.
like to see kidneys. Also, I like
No.
to see the kidneys to rule out putty kidneys.
What
Yeah, there is
happened
also.
here? What
Yeah, there
happened
is
here?
significant. Yeah, there is calcified focus in the spinal canal, and this is likely
This
this is
is
indenting and compressing the thecal sac. So this is
this is
emergency.
not
This
emergency
is
because this patient is a non-paraplegic, and as long as this is
okay.
calcified, so this is all. But you must tell the examiner about any disease in the spine if it is extended to the spine, intraspine or not. This is very critical. See here
Okay.
about subtotally occluding the spinal. So thank you, doctor,
Yeah.
so much.
Thank you,
Okay,
sir.
this is it was a case of tuberculosis spondylitis with multisystemic involvement, including the pulmonary, abdomen and the pelvis with intraspinal extension and gibbous deformity. This case may come in long reporting. Why? It is very easy, but in long reporting, you have a challenge of time management. So they are very are very tricky people. They bring one case like this to consume your time. No, write short, clear, precise bullets. Don't describe too much in cases like this. The most important to fulfill and to describe everything, but not in details. My advice for all of you in long reporting, give each case 12 minutes, not more. Even even what happened. Why? Long reporting is a time game. Thank you, Doctor, so much. Next
Thank you.
candidate.
Yes,
Hello,
sir. I'm here. Yes, sir. Yes, sir. I'm here.
Omer.
Okay, sir. I'm provided with the
No,
chest
1 second.
X-ray.
1 second. Dr. Omer, huh?
Yes, sir.
Or not? Dr. Omer, this is a very difficult case, by the way, but you need. I will
Okay,
help
sir.
you.
Okay.
You are
Okay,
helping
sir.
me too much in the session. Okay.
No, sir.
This
You are
patient.
doing great efforts for us. So, okay, sir. I'm provided with the chest X-ray frontal projection of a
One
healthy
second.
mature patient.
One second. 75-year-old female patient presented with a history of alcoholic liver disease and hepatitis C. Patient has large recurrent right, no, left pleural effusion.
Okay.
Go on.
Okay, sir. Sir, I can appreciate that there is a complete whiteout of the left hemithorax is noted, and then I can appreciate that there is contralateral mediastinal shift is also seen, and there is also mild contralateral mediastinal shift is also noted. The visualized right lung field appears to be grossly unremarkable. In my routine practice, I would zoom and also the window to look for any other bony abnormality or any other abnormality. So now
Receives the CT.
I will correlate it with the CT scan. Yes, the CT post contrast. Sir, should I ask for control?
Yeah, sure.
Okay, sir, I have requested the remote control.
Go on.
Okay, sir, I will first of all I will scroll to the top and then start commenting. I can appreciate that there is a gross left sided pleural effusion noted with the marked pleural thickening can be appreciated, and there is complete collapse of the underlying lung is seen, and there is nodularity, mild nodularity of the pleural, pleural thickening and nodularity is also can also be appreciated, and there are no calcifications I can see till now, and I will scroll down till the last image. Uh, okay, so there is also okay. The trendy changes noted in the left hypochondrium, and the adrenals are fine, and now changes of fat shaman. I would now look for any other obscuring lesion in the bronchus. So I'm going to scroll upward. Uh,
1 second, Dr. Omer. 1 second.
yes, yes, yes.
What is
Uh,
the cause? What do you think about the cause of this pleural effusion? Because it is recurrent. See, look
sir,
here.
this is there is proof. Yes, sir.
Follow this area, please.
So the,
Follow the down.
okay.
Down again.
Yes, yes. There is element of pleural thickening, and along with that, there is
No. Not 1 second. This one.
The thickening of the diaphragmatic pleura is also seen, and the crest of the diaphragm is also thickened. And
Okay, okay. See. What is the relation between this collection? Trace this collection up and down. This is a collection. Trace up and
yes,
down.
sir.
Trace the starting point and the ending point.
It's a
Go.
complex looking collection.
Yeah. Wait. From where does it start? I see. I'm trying to help you. This is still the collection here. And by the way, see at the edge of this collection, there are some enhancement and the capsule. Go down.
Yes, sir. Enhancing. Yes, sir.
Go down. From where does it start? What
Sir,
is
it is
this?
starting from the
Yes.
so from the base and dome of the diaphragm, from the crust, and also involving the uh, peritoneal cavity. It is also involving the peritoneal cavity as well on the left.
Yes. Excellent. But see, what is this?
Yes, sir.
What is the name of this structure?
It's a pancreas.
Okay. Look at its tail. Look.
So there is a hypodensity noted in the pancreatic
Yeah.
tail, and
See. What is this? Follow this hypodensity. Yeah. Follow.
yes, sir. This is focal dilatation of pancreatic tail, and
We are see.
okay. So I think there is an exophytic. Uh, okay, the tail is dilated, and then I can see that there is some exophytic structure arising from the tail, which is
Okay.
poorly enhancing.
Yeah. Peripheral enhancing. Follow it back. Follow.
Peripheral.
Follow. I'm indicated with the arrow. Still, this structure peripherally enhancing and centrally hypodense, still
Yes, sir.
still visible.
Yes,
This one.
visible, and visible.
Where is it go? Where is it
Okay, so
in?
it is going into the full cavity.
Yes, to the left pleural cavity. Excellent. So,
Yes,
tell me your
and there is a
diagnosis.
pancreatopleural fistula.
Yes, excellent. A very difficult case, but at least
Yes, sir.
we know one of the case for our knowledge. Thank you, Dr. Omer, so much. There are a large recurrent. The buzzword here in this is recurrent. As long as they
Yes, sir.
remove and drain this pleural effusion again, because it is connected to the pancreas again and
To the
again, it
pancreas. Yes.
accumulate. When we go down here, see from here,
Yes.
see
Okay.
around this one, okay, this track. There are peripherally enhancing track, fistula track, down, this one in the between the stomach and the spleen, and it will go down this one till the tail. Okay,
Till the
so
tail.
this is a pancreatico left pleural fistula complicated by marked left pleural effusion. It may be due to trauma, due to focal pancreatitis, and it causes releasing of the proteolytic enzymes, which destruct and build up this tract. Thank you, doctor, so much.
Thank you, sir. Thank you so much.
The management, by way here, my colleagues, this tract must be removed surgically. Okay, thank you so much. Next candidate.
Yes, sir.
Welcome. Would you ask for control, please?
Okay. I've requested. Okay.
This
Should I
patient,
start, sir?
yeah,
Yes.
this patient presented with severe headache.
Severe headache. Okay.
Yes.
All right. So this is the MRI brain axial section.
T1 sequence?
Not T1. Look at the fact.
No, flare. Flare.
Okay. Okay.
I can see that there are hyperintense foci noted in the right cerebral hemisphere in the region of centrum semiovale and corona radiata.
Yes.
These are in the deep white matter region.
Okay.
I like to see it on the T2 weighted images and yes, I want to see the T2 weighted images and
No, this is the only available sequence. What will you do?
okay. I'll look once again. Okay, I can see that there is hyperintensity noted in the region of right internal carotid artery
Yes.
over here.
Okay. Okay.
Yes, so as it's a hyperintensity in the region of internal carotid artery, so it could be due to any watershed infarcts, due to hypotension and narrowing of the ICA.
So
I like to see the DWI images to confirm that if there are infarcts, if there is showing diffusion restriction.
what's your provisional diagnosis? What's your provisional diagnosis?
My differential would be of internal carotid artery dissection or
Excellent.
yes, because
Complicated
it's
by
complicated by watershed area infarcts
excellent.
on the right side. Yeah.
What? Yeah. Tell me the management. Don't forget.
Yes. Next, I would like to immediately convey the findings to the referring clinician and will advise to for next
Yes.
DSA study maybe and angiogram for a proper evaluation of the arteries and
What
then
else? What else?
and
Which specialty would you refer the patient?
neurosurgery,
Neurosurgery or interventional neurology
interventional radiology
or
and neurosurgery.
interventional? Yeah. Thank you, doctor, so much. My colleague, please, most of you lost in the middle of the exam. You are have examination and you have some finding. Your next step, before you asking me, give me any clue. Tell me what are you thinking about? At least tell doctor, I'm thinking about an injury dissection here, complicated by watershed area infarction. Please, doctor,
Yes,
could you show me diffusion? Or please, doctor, could you show me leave the mouse, please? Leave the
yes,
mouse. Could you show me, please, if you have the angiography, the MRA, like this? But most of you are describing, and asking for another sequence. No, this is not acceptable. Okay. When
okay,
the examiner give you this is doctor, this is not this is advice is not against you, but this is for all. Okay. Try to smash and take the maximum information from the sequence that in front of you. Why, doctor? You make a major mistake. You see here, and then
yes,
you ask me for another sequence. So I
yes,
refused. Why I refused? Because see here, the pathology is here, the disaster is
yes.
here.
I missed it on the
Okay.
first instance. Yes,
Okay. So all this point is very important inside the exam. Then you can ask for others, and don't forget for management. يعني except one. Till now I examined 10 candidates. I think
yes.
two of them only tell me step by step till the management. Okay, my colleagues, don't wait the examiner till he asking you about the next step. Thank you, doctor, so much. Did very well.
Thank you.
It
Thank you so
was
much.
a right internal carotid artery dissection created by watershed function. Next candidate.